So I imagine you're wondering why you were instructed to watch this video. The reason I'm introducing this method for the upcoming seminar is based on the feedback I've received following experiences on the most recent mock oral board examination. While everyone performed well, there was a common theme relating to the topical or classical literature seminars. Preparation effort certainly wasn't lacking, but many times the seminars were the first time students were understanding key concepts and themes. It's not uncommon to get lost in the details when you're facing an overwhelming amount of literature to digest. Strategies that involve simply reviewing the abstracts only allow for the most superficial levels of understanding, making it difficult to achieve more effective educational objectives. Some changes that were made based on similar past feedback involved more detailed listed objectives, along with less busy work and having study questions available. While I think these have been helpful to some degree, I don't think they achieved the level of engagement desired. My goal with this video is to provide context to the literature you're about to dive into, a little bit of a preview and a little bit of a guide to help you recognize what key concepts you should seek to understand. It's too easy to get lost in the numbers of endodontic outcomes, and I don't want that to take away from your ability to formulate your rationale for assigning a prognosis to a tooth. So, not to give up a spoiler right off the bat, but you won't find the perfect outcome study in this collection of literature because not one exists. Every article you review will have flaws, some of them significant. While I expect you to be able to identify the flaws, you should also be able to explain how they affect the impact of the findings, without joining some of the cynics out there who use these flaws as an excuse to maintain their own biases. In a practice setting with excellent management software, like TDO, and individual patient investment, we could hope to ascertain our lifetime success rates for each of the procedures we have performed. Until then, however, remember that we're expected to practice according to the best current available evidence. We are also obligated to include our estimated prognosis as part of our informed consent. The way I like to look at outcome studies is to break them into predicting different factors into three categories: the preoperative predictive factors, the intraoperative predictive factors, and the postoperative predictive factors. Now, we like to think ourselves superheroes of saving teeth, and as endodontists, we have the skills to do so. But there are some factors outside of our control that the literature has shown clearly affect our success rates. Among these factors are periapical radiolucency, the number of roots, the vitality of the tooth, the presence of pulp canal obliteration, and even smoking. The most consistently found factor that affects our success rates is the periapical radiolucency. Sjogren found that without a periapical radiolucency, 96% success could be found. However, when there was a periapical radiolucency, only 86% success. The Toronto studies, Phase 4 with DeSchovigny and colleagues, without a periapical radiolucency, 93% success was discovered, and 82% with a periapical radiolucency can be expected. For obvious reasons, the more roots that are present, the better chance of detecting a radiolucency. For example, a molar with 3 roots has 3 chances to succeed or fail. And so for this reason, the Toronto studies also found that teeth with 1 root had a 93% success rate, whereas teeth with 2 or more roots only had an 84% success rate. One study that did not find periapical radiolucency to make a difference found that vitality did in fact make the difference, and that's the Tennessee study. Azim and colleagues in 2016 found that vital teeth were successful 94.4% of the time, whereas necrotic teeth only 72.1% of the time. In teeth with pulp canal obliteration without a periapical radiolucency, Eckerblom and colleagues found a 97.9% success rate. However, when these teeth had periapical radiolucencies, the success rate dropped to 62.5%. In their study looking at implants and non-surgical root canal treatment, Doyle and colleagues found that smoking was a predictive factor. The non-smoker can expect a success rate of 86%, whereas the smoker, their success rates decreased 20% down to 66%. Now, with the intraoperative predictive factors, we do in fact play a role. These factors include quality of root filling, intraoperative complications, which include perforations, fractured instruments, massive sealer extrusion, that's the poof instead of the puff, missed canals, transportation, and cracks. which techniques we use. Modern versus classic can play a role. Single versus multiple visits has been looked at frequently. And then also, who is the provider providing the non-surgical root canal treatment? When looking at the quality of root filling, length is often the consideration. Sjogren found that in teeth with periapical radiolucencies, the best success rate was found when the gutta percha ended 0 to 2 millimeters from the apex, with a 94% success rate. Once the gutta percha was past the apex, the success rate dropped to 76%, and when it was more than 2 millimeters from the apex, it was only 68%. In Phase 4 of the Toronto studies, Deshavigny and colleagues found that in teeth with periapical radiolucencies, the technique actually made a difference. So the technique of vertical compaction to obturate had an 87% success rate, whereas lateral compaction techniques resulted in 77% success rate. Now, they're important to note in their study that randomized controlled trials are necessary to determine if this truly is a factor. In the Tennessee study by Azim and colleagues, they looked at the density and the length. In teeth with good root filling density, 83.1% success was observed, whereas teeth with poor root filling density, only 12.5% were successful. Regarding the length, if the gutta percha was within a half millimeter of the apex, they had an 88% success rate. Once past the apex, the success rate dropped to 80%. 1 to 2 millimeters from the apex was 73.4%, and gutta percha greater than 2 millimeters from the apex was 33.3%. When looking at the intraoperative complications, the Toronto study also found that if there were no complications, success rates of 84% were demonstrated. However, once complications were present, only 69% of the teeth were successful. The Tennessee study also found that without complications, 84% success rate was observed, but with complications, their success rate dropped all the way down to 29.4%. When looking at modern versus classic techniques, considerations are made towards stainless steel hand filing, rotary instrumentation, microscopy, and multiple visits. Fleming and colleagues did a comparison of these two types of techniques, and they found no significant difference in survival. Now, in single versus multiple visits, that same study also found no significant difference in survival. That theme seems to be pretty common. Foggini and colleagues in 2008 found no significant difference in radiologic success between single and multiple visits. As endodontists, we would hope that we could perform better treatment and result in better outcomes for our patients. Burry and colleagues in a study at Marquette in 2016 found that 10-year molar survival was 89% for endodontists, whereas with non-endodontic providers, it was only 84%. Some factors are possibly within our control. Those factors include coronal restoration, and some have also looked at the possibility of orthodontic tooth movement affecting success rates. One classic study looking at coronal restoration is Ray and Trope in 1995. And one of the things that their study is remembered for is the technical quality of restoration was more important than technical quality of non-surgical root canal treatment. And they showed this because a good restoration had 80% radiologic success, whereas a poor restoration had 30.2% radiologic success. Good endodontics plus a good restoration resulted in 91.4% success. Gillen and colleagues in 2011 could not find a factor that was more important than the other. However, they did find that adequate restoration plus adequate non-surgical root canal treatment was 2.7 times more likely to succeed than inadequate restoration and adequate root canal treatment. When looking at factors related to the extraction of previously treated teeth, Zadig and colleagues in 2008 found that most extracted teeth with non-surgical root canal treatment were without coronal restoration. In fact, 57.4% of them were. When looking at teeth that were treated with orthodontics, DeSouza and colleagues found that while it did delay, the orthodontic tooth movement did not hinder ultimate healing of apical periodontitis. Regarding retreatment success rates, there are also some predictive factors. Again, the most commonly seen predictive factor is the presence or absence of a periapical radiolucency. In Sjogren's study, he found that in teeth that needed retreatment without periapical radiolucencies, 98% success rate was possible. However, with a radiolucency, only 62% were successful. In one of the favorite studies to quote, Gorney and Gagliani in 2004 found that if the root canal morphology was respected in teeth without periapic radiolucencies, 92% success rates were demonstrated, whereas with periapic radiolucency, only 84% were successful. The Toronto studies phases 3 and 4, which looked at retreatment, DeChavigny and colleagues in 2008 found that without radiolucency, 93% were successful, but with only 80% were. One of the other factors that plays a role in the success of our retreatments is the quality of the previous treatment. When it comes to anatomy and morphology, Corning Gagliani found that once that morphology was altered with the previous treatment, the success rates differed. In such cases, without a periapical radiolucency, only 84% of the teeth were successful. And when there was a radiolucency, it dropped all the way down to 40%. In the Toronto studies, when the root canal filling material was adequate from the previous treatment, they had a 66% success rate. But if the root canal filling was inadequate, they actually had a higher success rate with 88%. So go ahead and think about possible reasons why that could be. Also, they found that if there was no perforation, they could get an 87% success rate. But once a perforation was discovered, only 56% of those teeth succeeded. When looking at apical surgery, predictive factors that have been described in the literature include age, the quality of the previous treatment, the size of the crypt, and modern versus classical techniques. Referring once again to the Toronto studies, phases 3, 4, and 5 by Barone and colleagues, they actually found that older patients had higher success rates, with patients greater than 45 years old having 84% success, but less than 45 years old, only 68%. When looking at the quality of previous treatment, they found that if the previous treatment had inadequate root filling length, the success rate was all the way up to 84%. If the root canal filling length was adequate, 68% of the teeth were successful. The crypt size played a significant role. When crypt size was less than 10 millimeters, 80% were successful. Once it was greater than or equal to 10 millimeters, only 53% of the cases were successful. When comparing modern endodontic microsurgery with some of the classical techniques, Setzer and colleagues in 2010 found that microsurgery achieved success rates of 94% when using ultrasonic instruments, bioceramic materials, and microscopy, whereas traditional root end surgery, only 59% of the cases were successful. So that's just some categories that you can break up the success rates into to help make more sense as you're studying. Some of the other key concepts I want you to look at and consider is, when do we consider a tooth a failure? With initial treatment, we can always consider retreatment, and with retreatment, we can possibly consider surgery. So at what point is it success or failure? Also, a lot of discussion has been made about implants versus endodontics. Is it a fair discussion? What are some different factors that we want to consider for both treatment modalities? When we're looking at the outcome studies, it's important to look at how we evaluated the outcomes. Were we using PA radiography? Were we using the gold standard of histology? Or were we using three-dimensional imagery? And does that factor into how high or low our success rates are? Don't forget that once we finish the root canal treatment, we want to be able to monitor the success ourselves of our patients. And so we have certain protocol for when to do follow-ups. Where do we get that rationale? And what does literature suggest is a reasonable time to follow up on teeth? So these are just some of the concepts we look at when we're talking about outcomes literature. Hopefully this video helped guide you a little bit, and maybe it can also serve as a little bit of a review. Either way, you'll have to let me know. Happy studying.